Good morning, everyone. I'm going to let everyone get settled in virtually here. I see a few are still, Harold and Anne Marie, and a few others are still trying to get connected audio. So let's give them a chance to get connected in before we begin. Looks like a couple others are still trying to join. So let's give them a chance before we begin this morning. Really great to see all of you and really appreciate your patronage and attendance today. We've got a lot of really good information to share with all of you. And we're also hoping that we can get some, some interaction and feedback from all of you. The second part of our presentation today is going to be a little more interactive. We'll be breaking into some smaller groups, and if our group stays this size, they will be very small groups. So we'll be doing that in the second half, but first we want to set the table today by really opening up some discussion and taking a good broad view at some ethical considerations regarding behavioral health. And this includes substance use disorder providers, it includes social work professionals, and it would include mental health and behavioral health professionals as well. So this is a broad umbrella, and we know that Ed and I will talk more about this as we get into today's presentation. So I do have on the call as well today. I have Noah Siegel, who works out of our Chicago office. He is going to be supporting the first half of today's presentation technically. So he'll be monitoring the chat and helping anyone. If you're having any technical difficulties, please reach out to Noah via chat, and he should be able to assist you. And then we'll have a couple other staff members joining for the second portion of our broadcast today to assist in that same manner. Also on the line is Donna Anfield, and some of you may know Donna. She and I and Ed and others here at the Native Center for Behavioral Health have been collaborating over the last several months to bring you these ongoing sessions. So really happy to partner with and collaborate with the Bemidji IHS region on this important endeavor. So Donna, great to have you here, and I'll let you say hello to folks here once we get started. And then of course I have also with us is Mr. Ed Parsells. He is my co-presenter today, and Ed is a senior consultant and also part of our advisory council, and he's also my colleague, and I consider him a good friend. So Ed, really happy to have you on as well, and you guys are all in for a great presentation today. So welcome to Walking in Two Worlds. This is the this session today regarding behavioral health challenges of living in living native in a non-native world. We have session 8, professional and ethical considerations in behavioral health. Just have a few intro slides, and then we're going to transition to our primary slide deck, and we'll get started. This project, as most of you know, continues to be supported by the Native Center for Behavioral Health at the University of Iowa. My name is Steve Steine. I'm one of the managers here at the Native Center for Behavioral Health, located at the University of Iowa at the College of Public Health. The content of today's presentation is developed by the presenters, and the opinions expressed do not necessarily reflect the views or policies of the Native Center for Behavioral Health, the University of Iowa, or the Bemidji IHS area. Following today's presentation, you will receive links and a link to the recording of today's session, in addition to a PDF version of the slides that you can access and use as a resource for yourself or your respective agency. There'll also be information on how to request and receive NADAC or University of Iowa social work approved CEUs. If there may be those of you that are needing CEUs, this should meet the requirements of the 3 CEUs for a certification or a licensure that's often needed in a reapplication of those credentials. So we're happy to provide those. You'll just need to discern with us whether you need social work or NADAC approved CEUs. I know we're gathered here virtually today, but I do want to take some time to acknowledge the land and pay respect to the indigenous nations whose homelands were forcibly taken and inhabited. Please take a moment to read this land acknowledgement, which was created by 3 members of our team, Ella and Keely Driscoll, and our co-director, Mr. Sean Bear. Thank you. So without further ado, I want to introduce our speaker today, Mr. Ed Parsells. Ed Parsells is an enrolled member of the Cheyenne River Sioux tribe, and he has served as the clinical director for the Rosebud Sioux Tribe methamphetamine rehabilitation program in Rosebud, South Dakota. And he is, as I mentioned, currently employed as a senior consultant with the National American Indian Alaska Native ATTC, and also works in collaboration with our center here, the Native Center for Behavioral Health. And he's been a longtime advisor of the advisory council there as well. So we're really happy to have him here. I know Ed is recently retired, but we are sort of ignoring that and keeping him as busy as we can. So Ed, really glad to have you here. And I'm also going to be co-presenting today. And as I said, my name is Steve Steine. I worked in the clinical services world for many years as a clinician and as a administrator and manager. Worked in the substance use disorder field in a nonprofit clinic for many years, and have been here at here with the Native Center for Behavioral Health since 2019. So really happy to have you all here. I'm going to stop sharing here and try and pull up the next slide deck. So just give me a couple of moments. And let's see if I can do this without breaking anything. Okay, I think we're just about ready. Donna, would you like to say a couple of words to the audience just regarding our continued collaboration and work together?
Certainly. Thank you. I just want to thank everybody for joining today. Appreciate you taking time out of your busy day to join with us. Happy about the collaboration with the University of Iowa and looking forward to a great presentation on the very important topic of ethics. If anyone has any questions, feel free to put them into the chat. Hopefully we'll have a lively discussion in part 2 during the breakout sessions. And so enjoy the presentation today. Thank you again for being here.
Well, thank you so much, Donna. I appreciate your continued support and continued involvement in this ongoing project. I think we're now 8 sessions into 10 planned sessions, so we're nearing the conclusion. But it's been really important for us to continue working together. So thank you so much. Noah, are we seeing the full screen? Does this look okay, everybody?
Yep, looks great.
Oh, that's great. So Ed and I are going to co-present today, and we'll be kind of passing things back and forth. And we do have at the end of, right before we take a short break at the midpoint, we do have a short quiz that we're going to do with all of you. It's more just to get sort of your analytical ethics cap kind of warmed up. And then when we return from break, we're going to break into smaller groups and have each group work on an ethical dilemma through the format of a short vignette or a short story that provides a sort of an ethical dilemma. So we'll talk more about that as we get closer to wrapping up the conclusion of the primary slide deck. But I wanted to just kind of prep you for that. I really hope you can stay with us today throughout this webinar, and we really look forward to hearing from you as well. You are muted, but feel free to unmute or post something in the chat or use the hand raise feature if you really want to say something or have a comment or question. And I think Ed and I will try and take those questions as we go. So again, great to see all of you. Let's get started. So today's presentation, it's March 2022. Can't believe it's already March. Today's title is Professional and Ethical Considerations. Some of the things that I want us to sort of keep in mind as we go over today's webinar and workshop are we're going to be covering ethical principles, including autonomy, non-maleficence, beneficence, social justice, fidelity, and veracity. We're also going to look at the 13 principles of effective treatment. And those of you that are currently providing treatment services, I think this will be maybe review for you. And if some of you are new to the field or maybe working in a parallel field to substance use disorder treatment, this will be maybe a good introduction to some of the components to effective treatment or the effective service in the treatment of substance use disorders. We're also going to look at least give a nice overview and take a look at some different professional codes of ethics. Now we're going to use some of the references to some of the Iowa Code of Ethics, but all of these codes of ethics are available in your respective state. I know we may have some audience members outside of the Iowa, Minnesota area. So keep that in mind. Any code of ethics that we're referring to, it'll either be a national code of ethics or it may be a state-oriented code of ethics that each of you would have access to in your respective state. We're also going to look at some ethical responsibilities. Codes of ethics, patient rights, mandatory reporting, boundary issues, and the use of supervision. We will also be just some things to keep in mind, just some vocabulary that's specific to this presentation today, morals, principles, ethical values, and most importantly, in my opinion, the scope of practice. So I want to open up the discussion here and talk a little bit about the principles of effective treatment. There are a couple of things to keep in mind as we go through some of these. This first one, I think, is important. Substance use disorders are a complex but treatable disease that affect brain function and behavior. And I would note that people can and do recover from substance use disorders. And sometimes we may say that they are in recovery or recovering, but I want to make it clear that there is a possibility for recovery and a return to a functional quality of life. It's important to note that. It's also important to know that there's no single treatment that fits everyone. So this notion of different pathways to recovery or to through treatment is very important. It's not one size fits all, and you cannot really put a square peg in a round hole. You can try, but sometimes it really is problematic. So the notion of one pathway or approach to treating substance use disorders is just not sustainable anymore. There may be common themes or particular approaches and programs that work better for some than others, depending on a variety of factors. Can anyone think of an example? If you think of something, an example maybe to post in the chat to kind of help us, help the audience understand this. And then lastly, on this notion, this notion or idea of readiness to change. Also the presence of any co-occurring or underlying disorders, other factors such as gender or trauma history or the age of the patient are all things to consider when we look at what is the best course of treatment for that patient.
Also, Steve, I know some of our, I know we've had trainees in the past, especially like on the exam, taking the exam. Some people tend to perceive things from their own perspective. And I know that some agencies utilize a single treatment model.
Yeah.
But ethically, we need to be aware of other types of treatment that may be equal or even in some cases superior to what we're using in our agency.
Yeah.
So we just need to be aware of that and accept that as a reality.
I appreciate that, Ed, and I agree. Some other bullet points here that I want to touch on is before we move forward is this idea of the various types of treatment. They need to be accessible and available. So in other words, mental health services, perhaps family or couples counseling could be related to gambling disorder or legal issues, could be child custody issues, et cetera, medical, access to medical or substance use disorder treatment services. So that's something to keep in mind. Effective treatment attends to multiple needs of the individual, not just his or her drug use. And this ties into this idea that, from a biopsychosocial perspective, I view and often viewed patients in that light, that their substance use was not the problem, that it was causing problems, but there really was some other underlying issues that were driving this use. And so if I am able to connect and build rapport and mutual trust with that patient, then I would be able to, in theory, explore some of those underlying issues. And so that's something to keep in mind as we move forward as well. And
treatment.
Mm-hmm.
Treatment, the term also, it encompasses the entire continuum. So the modality from inpatient or outpatient, intensive outpatient, residential or inpatient, and then a variety of sources of continuing care. It could include a halfway house or that type of thing, but all of that is considered treatment.
Yes, that's true. And some of the most important work happens post-primary care. And if we follow a medical model, it wouldn't make sense to, as the patient, the way that it works now is when the patient improves, we pull services away. And when treating substance use disorders, this is often we need to have sort of an opposite approach in really backloading services to give that patient as much support as needed when they complete their primary care, so that they can transition back into the community without and reduce their potential for relapse. And lastly, on this slide, just remaining in treatment for an adequate period of time is critical. And this notion or idea of length of stay, unfortunately, is often program driven. It's often driven by third-party payers. And I know that many of you out there have experienced this with your patients rather than having it be patient-driven. So length of stay is something that we also consider and look at. If you're interested in any of these principles of drug addiction treatment, they are available through the NIDA website. And you can explore them more closely there. A few other things to consider. Again, this idea of effective treatment. Behavioral therapies are the most commonly used form of substance use disorder treatment. Cognitive processing therapy, cognitive behavioral therapy, and dialectic behavioral therapy, DBT, are just some examples of that. Medications are an important element of treatment for many patients. The assistance of medications, whether it be pharmaceutical or, for example, to address opioid use disorders, is becoming increasingly widely accepted in the behavioral health field. However, not all patients will need medication to experience a meaningful recovery process. So it's not a default, but it's something to consider. Also, an individual's treatment plan must be assessed continually and modified as necessary. And those of you that are doing treatment planning with patients know this full well. That treatment plan is a living document. What does this mean? What do I mean when I say it's a living document? Anybody want to throw a comment in the chat about this? Or unmute and give us a little something. What is it? What do I mean when I say a treatment plan is a living document? Ed, what do you think about that?
Well, I know several. I have stories to tell, but I know some of the most common are you have an assessment, and of course the misuse was identified, and then in the last week in the 30-day treatment program, this is pretty common. A client is going to disclose for the first time in their life that Uncle Bobo touched them wrong when they were 8 years old. So now that treatment plan is going to have to be modified to now include, potential sexual abuse in childhood. That's one example.
That's one example. Yeah. So a couple others commented. Thank you, Ed. A couple others commented. Donna said the goals change over time as the patient progresses, and Brittany said it evolves, and Paulie said it can change at each visit depending on patient needs and situations. So you guys are all spot on. The idea is it's not a stagnant document. And
I gotta throw in my little disclaimer here too. I did this. I said that in a one setting, and then here somebody raised their hand and said, "My uncle's name is Bobo." No, this is not in reference to anybody else.
Right. Yes. All the Uncle Bobos out there just need to know that this is not meant to incriminate anyone.
Yeah.
Also this idea that an individual with a substance use disorder may have mental health issues. There are studies suggesting that as many as 2 out of 3 may have a co-occurring or comorbid mental health issue underlying their substance use disorder. This notion makes sense, and on a much broader, again, biopsychosocial scale, it really fits. I want you to consider broadening your definition on this idea of co-occurring disorders. Think about the human condition. Issues like grief and loss, trauma, chronic pain, all of these can be considered co-occurring issues. I also want you to think of a person's substance use as a symptom or indicator rather than an underlying, or as a symptom or indicator of an underlying co-occurring disorder. It's important to keep this in mind. And maybe some of you already are ahead of me on this. Lastly, on this slide, detoxification is only the first stage of substance use disorder treatment. And detox very well may be the first stage, but it is a vital step in the continuum of services that Ed mentioned, particularly with patients who have moderate to acute substance use disorders or exhibit signs and symptoms related to withdrawal. Think of it as stabilizing not just the body, but treating the brain as an organ that has been compromised. Until we treat the brain disorder and properly detox a patient, progress along the substance use disorder treatment continuum will be wrought with liabilities. So it's something to keep in mind. And I'm sure this makes sense to those of you that are working with patients in the substance use disorder field. And yeah, Donna, I agree. This also would apply. She sent me a message saying this would apply in a mental health clinic as well.
Yeah, and then a detox also extends, there's medical detox, which is basically 72 hours of physical withdrawal, but also social detox that can apply. And
yes. Yes, thank you, Ed. And I see Doug's got his hand up. Doug, did you have a comment?
Yeah, I just wanted to say, I've been saying this for quite a few years now, that we need more dual diagnosis facilities. We need, well, most of my clients are drug and alcohol related, but they have a lot more mental issues to deal with first.
Yeah.
And, you know, it's rough because some people just don't get it.
Yeah. Appreciate that, Doug. I think there are many of us that would agree. And really the trend right now is to treat the whole person and to treat them concurrently so that it's being done. It used to be you have to treat this before that, but now really the notion is that you have a mental health substance use hybrid clinician that can do it all and can make referrals and can connect that patient and work with that patient on all levels. To wrap up these 13 principles of effective treatment, treatment does not need to be voluntary to be effective. Now this, sometimes it can be a little controversial, but the research that I've seen, it really shows that mandated treatment versus voluntary treatment, the outcomes are almost identical. So whether a person is there as a self-referral or mandated through a third party, the outcomes are often very similar.
And then for meth treatment, just my anecdotal comment is that court-ordered treatment to meth is the success rate was, if they're court-ordered, I think it was like 60%. And for those who voluntarily walked into meth treatment, it was like 5%. So the court order mandated was tremendously more effective. Meth treatment is a tricky creature, but the court-ordered people, especially with federal court-ordered mandated treatment, tend to help people stay into treatment. And if they weren't court-ordered, they'd get to feeling good in about 2 weeks and say thank you, and this has been a wonderful experience, and then they walk out because they don't have anything keeping them there.
Yeah, good points, Ed. I know that mandated versus voluntary treatment can be debated quite a bit. But yeah, when there's initial push and support through drug courts or through some strict probation or parole supervision, it can have a positive effect for sure. A couple other things to consider before we move forward. Drug use during treatment must be monitored continuously, as lapses can and do occur. We know this. This is important and must be handled with clinical consistency and objective considerations. Most treatment centers, as we know, are abstinence-based. Thus, continued use of alcohol or other drugs may require an increase in level of care and or may involve more serious consequences if a third-party referral is involved, such as Ed was saying. If they're mandated, they may have more riding on whether or not they're able to provide a negative urine screen, for example. However, we don't have time to talk about this, but other considerations such as harm reduction and a non-abstinence-based approach are also considerations that might be, if we have more time, we might talk a little bit more about. The last point on these principles of effective treatment, patients should be tested for HIV, hepatitis B and C, and tuberculosis and other infectious diseases, as well as targeted risk reduction counseling, linking patients to treatment if necessary. This is not only good patient care, but it is often state mandated that because it poses overall health risks to the public as well as patients and staff. So something to keep in mind as well. I know Ed probably could speak on this as well, but I want to make that clear that testing for these types of medical conditions are important to protect patient population and staff as well. Okay, let's see if I can get this screen on. You guys are in my way there. There we go. Let's take a look at the foundations for understanding. So it's just some vocabulary, again, some things to kind of keep in mind as we speak. We're gonna throw around terms like professional and ethical responsibilities, values, morals, and perspectives. We're gonna draw a distinction between legal and ethical dilemmas, and we're also going to look at some ethical values that are connected oftentimes to the respective code of ethics within your discipline. I want to turn now and talk a bit about scope of practice, and I think this is an important element to consider, as oftentimes we find ourselves perhaps working with patients whose needs are beyond our ability to treat. So it's important for us to keep this scope of practice in mind. Some things to consider. We're going to talk a little bit about general counseling theories and treatment methods, screening, assessment, and diagnosis under this umbrella of scope of practice, treatment planning and case management, whether you're providing individual, group, or family counseling, and then also patient, family, and community education, whether you're doing early intervention or some primary prevention care. Ed, should we talk a little bit about the distinction between legal and ethical dilemmas?
Absolutely. Just want to comment too. I noticed that somebody made a comment about culture, and that's
Yes.
There's what the field recognizes as best practices. Those are tried and true, scientifically validated. And then there's promising practices that have shown merit, but haven't achieved the status of a best practice. And then there used to be a cultural-based practice for Native Americans, which is also a consideration. So cultural-based practice recognizes the integration of tribal, Native American ceremonies, practices, beliefs, integrating that. I know Gene Thinnow, he's the one that developed the concept of the Red Road approach, and that's integrating culture into whatever method or modality you're using for treatment. So we want to recognize as well that the cultural-based practices in treatment. I know for Native Americans, especially those that are oriented to their culture and belief system, are essential, and they become extremely effective. So I just wanted to comment on that, throw that out there.
I really appreciate that, Ed, and Doug. Thanks for posting that in the chat. So I do appreciate that. I want to just draw visually a distinction here. If you can look at this slide and see the idea of ethical dilemmas versus legal, and sometimes there is an overlap. Sometimes we're going to see an enmeshment of these, but it's important to draw a distinction between the two and to really think of ethical dilemmas really as aspirational, and really looking at how we do what we do, what guides us in our practice and application of our trade and our work with patients. And if this idea that if it's not self-monitored, that we have sort of a governing overview or some outside agency that can step in and help enforce ethical standards. Also, this idea of safeguarding autonomy of the professional practitioners. These ethical dilemmas are dynamic, complex, and are evolving. It often comes down to interpretation or a matter of opinion, and this can get a little bit slippery and a little bit gray. And lastly, it's not always a legal concern. There may be at times some legal considerations, but it's not always. And then on the other hand, the legal dilemmas are often determined by a federal or state governing body or statute or law. There often include corrective measures, an effort to sort of oversee the profession. There may be some legal issues versus this sort of professional expectation or integrity. And there's a legal aspect if ethics are consistently violated, particularly with certain types of ethical violations that are also criminal in nature. There's the notion of civil or criminal, and the enforcement of certain legal dilemmas often sets a precedence or sets a historical reference for how they're handled in future cases.
So, I've been asked, what's the difference between an ethic and a rule? They're very similar. It can be, but for the law, that's very concrete. So here's the law. Violate the law. Here's consequences. Soften that up a little bit. Here's a rule operating much the same way. So here's concrete language for a rule, and here's consequences for breaking the rule. Ethics are a little more fuzzy around the edges and kind of border more on philosophy than rule. But they still serve as guidelines to kind of keep our behavior and conduct within professional boundaries.
Thank you, Ed. And I want to touch on duty to warn And I know many of you here today and listening have, if you've taken an ethics course or done any work in area of ethics, you are familiar with the Tarasoff decision. And as most of you know, this relates to a court decision and has meant that if a person is in danger from a person with a mental health or behavioral health issue, that they must be told, as well as notifying the authorities. Essentially, the Tarasoff decision means that the therapist must tell the authorities if a patient is a danger to another person. It's a case that set the precedence. So we're not going to go into the details of the Tarasoff decision, but Ed, I don't know if you have anything to add, but this really was what established this notion of duty to warn.
Yeah, and also the patient or the client, they need to be informed of the potential threat.
Yes. Agreed. Thank you. Let's talk a little bit about ethical values, and these are really the cornerstones or the foundational pieces of what it means to follow professional and ethical guidelines and have that responsibility. Be good, do good, and above all, do no harm. Professional and ethical responsibilities. So these, as we've sort of alluded to, adhere to established professional codes of ethics. The guidelines are there for you to follow, whether they are in the social work field, the nursing field, substance abuse field, mental health field, etc. They adhere to federal and state laws and agency regulations. These federal and state laws often supersede ethical standards. So it's something to keep in mind as we look at where our responsibilities lie professionally. And as Ed alluded to, you interpret and apply the information. So, I've often said, early on in my career, I often relied on supervision support to help interpret and follow some ethical guidelines. And of course, looking at past precedents, how did we handle this in the past? For example, if a patient brings in a gift, they bring in a cheese and meat tray. This is for Steve because he really changed my life. And what I can say in our agency policy was that I couldn't accept that meat and cheese tray, but I could accept that on the behalf of the agency. And it was then an agency. It was an agency item, not a personal item. That's how we handle these kind of things. That was our ethical sort of interpretation of acceptance of gifts. That's just one example. I don't know if others have examples, or Ed, if you have something to say about this slide or anything related to it.
When, like you said, it gets, I know our Native American people can tend to be very generous. And as the director of the meth program, at graduation, our staff would be ambushed with gifts from the families, and even like they would try to give me personally a star quilt, but I accepted that on behalf of the program, and now that becomes program property.
Yes.
Now I've been awarded an eagle feather in a graduation ceremony. They ambushed me with that. Now that I get to personally keep, but anything of monetary value needs to be cleared with a supervisor or administrator for the agency, and they'll make a determination on how it is to be accepted.
Yes. Thank you, Ed. I appreciate that. Some other things to consider when we're looking at professional and ethical responsibilities. Recognizing the importance of individual differences. This I would argue is fundamental to good clinical practice. Number 5, utilize a range of supervisory options. Your supervisor, and I believe this strongly. I was fortunate to have a great supervisor early on in my career. Your supervisor is a resource for you to use and faced with ethical decision-making situations, whether it is a routine or significant event. Your supervisor or manager will likely have some experience and or some precedence to assist you in making the right call. So it's really a vital resource. And then number 6, ongoing supervision and annual reviews can serve as a means for professional development and growth. It can help you evaluate your own professional development, and may lead to some self-care or other techniques or practices to help you sort of check yourself where you're at ethically. Some other considerations, continuing professional education. That's what we're doing right here, right now. A good ethics training can provide foundational components for a new clinician, perhaps entering the field, or it could be a vital review for the experienced clinician, especially in matters surrounding mandatory reporting or child welfare. Number 8, participate in ongoing supervision. Again, ideally, an ideal model, would be a weekly to bi-weekly supervision meeting with your supervisor or manager. Private practice can be a little more challenging. Sometimes you're working independently or in a small group. So I would suggest, finding a colleague or mentor to assist you in that sort of self-check and ongoing supervision. And lastly, as I referenced a little bit earlier, maintaining one's own physical and mental health. Self-care, we know, is absolutely essential. It's sort of a term that's overused a bit, but your family, your colleagues, and your patients will benefit the most by you taking care of yourself. So something to keep in mind from an ethical standpoint and your responsibilities to this profession. So this slide just refers you to the NADAC Code of Ethics webpage. It's the National Association for Addiction Professionals. This can be a great guideline, ethical guideline, if you're working in the substance use disorder field. So something to consider. But you refer to your state specific code of ethics regarding your discipline or wherever you're living for additional information. Code of ethics examples for alcohol and drug counselors. These are just, we're not going to go through these one by one, but I do, Ed may have a couple of comments here. I can speak to a few of these, but they really are outlined here on this slide. Responsibility to patients, that idea of non-maleficence, dual relationships. That's fairly self-explanatory, but we'll touch on those later in the presentation. Confidentiality, it's the holy grail in the substance use disorder world. Treatment, the confidentiality is it. It is the gold standard for how we protect patients and their rights to privacy. Professional competency and integrity. Responsibility to students, employees, and supervisees. I know in my clinic, when I worked in my clinic, we often had practicum students or interns, and I had ethical responsibilities to see that they were safe and supported. along with my supervisees and my fellow employees, colleagues, and peers. Responsibility to the profession. Also, ethical examples regarding financial arrangements. That can be a difficult barrier if a patient does not have access to health insurance, or you don't offer a sliding scale at your agency. It can be a barrier and make it difficult for patients to access services. Advertising. So in other words, providing the services you say you're providing, and to do that within your scope of practice. And lastly, legal and moral standards. So those ethical and legal sort of that dichotomy, working in tandem with one another, really serves to guide those of us working in the substance use disorder treatment world. Ed, other thoughts about any of these?
Just that confidentiality. I've had the misfortune actually being subpoenaed and court ordered into court, and in the process, not that I'm all that, but I actually educated a judge about 42 CFR, and she had heard about it, but she didn't know the intimate details of it, and she actually charged me with contempt of court for not breaching 42 CFR. So 42 CFR is the most stringent, the strictest of federal regulations regarding confidentiality, and it was developed for the field of substance abuse primarily. So you have the Privacy Act and HIPAA, they also come into play, but 42 CFR is a powerhouse, protecting the field and the client. So.
Yeah, I always think of 42 CFR as sort of like HIPAA on steroids. It goes above and beyond. I remember once, Ed, I had a federal agent threaten to arrest me if I didn't let him into the facility and let him access the patient that we had there, whether he had an arrest warrant. And that was unsettling to have a federal agent threaten to haul you away. And I think he was just trying to see if he'd get me to cave. And I didn't. I said, orange is my favorite color, sir. So, go ahead, do what you must. But I can't confirm or deny that patient is receiving services here. It was a good lesson learned for me. Let's talk a little bit about, and I appreciate your comments, Ed, too. I really do. Let's talk a little bit about agency ethics. And there are 4 bullet points here that I want to touch on, and I would really encourage some feedback from any of you, or if you have some thoughts on some of these bullet points, please feel free to jump in there. The first one, I think, is for me as a person in long-term recovery. This was something that I faced early on in my practice. This idea of disclosing my own recovery status. Now, a patient asking you, "Are you in recovery?" This question can be a slippery slope for a lot of clinicians. In the past, many substance abuse counselors were by default in recovery themselves. As a field, it was made up almost exclusively of those in recovery. As the field, however, has evolved over the past 30 years or so, this has changed. Disclosing one's recovery status can be beneficial to a patient if done appropriately. Yet this must be given careful consideration and done with the patient's best interest in mind. I had the misfortune of working at an agency that did not allow staff to disclose their recovery status to patients. And they had reason for this. And I accepted that, but it was at a cost. It was often difficult, and to not at least be able to have that option to share a little bit about your own recovery. So it was prohibited for us to share recovery status. And again, reviewing your agency's policies regarding self-disclosure may also be a decisive factor in your willingness and ability to disclose your own recovery status. The field now, as many of you know, is made up of both recovery and non-recovery staff. And I believe that you can be just as effective, whether you're in recovery or not, when connecting and working with patients. So I don't think it's by default a requirement any longer to work in the substance use disorder field. So I think also what we also are seeing, and Ed and I have talked about this, is this resurgence of peer recovery coaching and peer recovery support. So this almost requires you to be forthcoming about your own recovery and may be more acceptable now than it has been in previous decades. So it's a really important topic, and I think it's important to note that. So Ed, any other thoughts about disclosure of personal recovery?
Yeah, just dump some personal experience with this. Like you said, most of us backed into the field. We got into recovery, and then people started paying us for what we knew, and then they started calling us a counselor, and then we got the job. But nowadays, I hired 2 counselors in my meth treatment program, and both of them were abstinent all their life. And I'm like, what? But the one, she's a PhD candidate, getting educated now. She left the program, and she's pursuing full-time her doctoral degree. Never had a drop of alcohol or used drugs in her life. She's a drug and alcohol counselor. I just want to make this observation. And I did some research on this. I can't cite this, but I do know that if you are in recovery and you disclose that, you only disclose it to further the goals of the person that's in recovery. It's never about yourself. Yeah. But that has been abused. Some people wear it like a badge of honor. Yeah, you got a PhD, but I'm in recovery, so I'm superior. See how that it can be a very divisive element, especially among the staff. Yeah. Again, my experience has been I know this counselor firsthand. She was a more effective counselor than my counselors in recovery. She was more effective, and that was an eye opener for me. So I've seen it firsthand. The other thing, sometimes people that are in recovery, we got some baggage. And sometimes that can really interfere. So I just want to. That's more information that you needed, but just food for thought.
Thank you, Ed. I appreciate that. Just a couple other bullet points. We won't belabor these, but I want to make sure that we note the importance of mandatory reporting. Including adult dependent abuse and child abuse. These are often required by agencies that you complete. I think ours was every 5 years we had to do a retraining. Some agencies, the timeline varies, but also just regarding acceptable practices. So again, you look to your agency's policies and procedures and follow those and see how they mesh with your own ethical and moral guideposts, and make sure that you're in line with those, and what you're doing with the patients, how you're doing this is an acceptable best practice pathway. And lastly, culturally appropriate practices. Now, Ed, I'll let you touch on this a bit, but culturally appropriate counseling is important when forming the counselor patient relationship. Also, it is key that the clinician understand the patient's cultural characteristics and is always in a continual process of self-reflection of their own socio-cultural beliefs and biases. Ed, anything to add to that last?
Probably way more than we need, but I
know.
do want to make a comment. Just culturally appropriate, that can bleed into our own personal spiritual path, journey, whatever. And we got to be very, very careful not to impose our belief over a client or use our belief system to influence a client. That can be unethical. Now that works both ways. I've had some Christian-oriented counselors that say anything of the native culture is devil worship. Well, you can't operate appropriately in a Native American program with that position, but I've seen it. And then on the other end of the spectrum, I've had Native American traditional counselors that say that Christianity, that's white man's ways.
Yes.
So you see how that can be on both sides, and
Yes.
And we have to operate from the middle and be sensitive, first of all, to the client's needs and where they are. And if so both of those extremes, you can operate unethically in your practice if you try to impose your belief system on a vulnerable client.
Thank you, Ed. Moving forward, I just want to note here, these examples are from the state of Iowa, but it's important for you to know your specific procedures in filing and processing ethical complaints and violations. So each state has respective pathways to pursue this. These are just some examples of how this would be done in the state of Iowa. Let's talk a little bit about patient rights. Ed, I think this is also an important component when we're looking at when we're making some ethical considerations. When we look at patient rights, we are considering several key components: non-discrimination, of course, confidentiality, responsibility and competence, and informed consent.
So the non-discrimination,
Yes.
that covers the gamut of race, sexual orientation, gender issues, age, and again, like I said, your own spiritual bias. You can't discriminate. I think religion used to be in there, but that spiritual belief bias, you can't discriminate against clients based on any of these. Personal issues, again, there's we're going to get into transference and countertransference, but we have to be very careful. And if I did have a counselor that worked for me that got into some serious trouble because his belief system interfered with the client, and he imposed it, and wound up losing his credentials. Our program, there was a threat with a lawsuit because he had issues with homosexuals, and he couldn't work with homosexuals based on his spiritual belief system, and he inappropriately imposed that. So that cost him. He's no longer working in the field. I'm still in touch with him. He's a good person, but you got to be very careful about that. Plus your own bias. If you have bias. Now, I took a graduate course, and of course I went into that saying I have no bias. I'm completely 100% neutral, and And I came out of that class with a whole list of my personal bias. So, you know, and again, we have issues, and we need to be aware of our issues and not allow them to interfere in a counseling relationship.
Yes. Thank you, Ed. And you said that was in a graduate course. Was that when they lit the classrooms with the whale oil lamps? Was that back in those days? You set me up for that, Ed. I couldn't. It was like low hanging fruit. I'm so sorry.
Well, I'm going to do some. Here goes some more disclosure. I started my graduate program in 1991, and,
okay.
and I'm 2 classes away. But I'm in recovery, so the ring of a BS behind my name just tickles me.
Let's talk again, just to briefly acknowledge and stress the importance of confidentiality, consent and confidential information, the patient's confidentiality rights. If you're not familiar with 42 CFR Part 2 and the Health Insurance Portability and Accountability Act of 1996, please feel free to research these or talk with a colleague. But very important when you're working with patients to know about confidentiality. So
the releases of information too, you know, they have to be 42 CFR compliant. I actually received from the state's attorney in South Dakota sent me a release of information regarding the client. It was not 42 CFR compliant. And I refused to release the information based on that. Yeah. And that has been changed now. So the state of South Dakota's release of information from this is from the I believe it was the Attorney General of South Dakota. That's where it wound up. And now their release is 42 CFR compliant. So you got to pay attention to that. If just because you get a release of information from whoever, wherever, if you're in an agency, a federal agency or a federally funded agency, you're bound by 42 CFR, and a release of information has to be 42 CFR compliant.
Okay, let's keep moving. There were some revisions made to 42 CFR Part 2 in July of 2020. We'll touch on those briefly, but we're not going to have time to really delve into them too deeply. I do have a couple links embedded into this PowerPoint if you're interested. The revisions were really addendums, but really do not affect the integrity of the overall rationale behind 42 CFR Part 2. So again, confidentiality, adhering to federal and state confidentiality laws, know the expectations, or know the expectation. I think that should be exceptions to federal law, and know how to respond to law enforcement requests for information. Again, I would use my example of being threatened with arrest. That's an extreme example, but the idea of presenting only necessary data, only presenting what is asked for when there's a proper written consent, and not releasing anything else. That should be, know the exceptions to federal law. So examples of exceptions to 42 CFR would be things like medical emergency, records audit, crime or assault on person or property. And then this idea of, I cannot confirm or deny. And as Ed mentioned earlier, a subpoena does not necessarily compel you to breach a patient's confidentiality or to provide records. Again, just touching on HIPAA and 42 CFR Part 2. Except under certain specified conditions, both HIPAA and 42 CFR Part 2 laws prohibit the use and disclosure of records or other patient-related information. We know this. There were some revisions. I note here what has not changed. There's the 42 CFR, even after the mild revisions, remains very stringent and is designed to protect patient records and rights and privacy. If you're interested, these are just the next 3 slides are just some of the amendments that were made. If you're interested, these are available at the Health and Human Services Archive if you want to look a little closer at these. But a couple of them are related to information being disclosed through personal devices, laptops, iPads, phones, things like that. But I think these are in response to some of the technology and changes that are happening with electronic health records and the redisclosure of and resharing of information. Ed and I talked prior to coming on. At first glance, it looks as though there's been some compromise to 42 CFR's Part 2's integrity, but I can assure you that the fundamental components remain. These slides are just for you to just a quick glance. We're not going to have time to go through and talk about these, but I wanted to make those available, and we'll have those in the slides if you're interested. Let's talk a little bit about responsibilities. Policies and management assist others with knowledge acquisition and report unethical behavior to proper authorities. These are all fairly self-explanatory, but I think you want to look to your policies and procedures in your agency. You want to assist and mentor others when it comes to ethical responsibilities in practice. And you have a duty to report unethical behavior to your supervisor or your agency CEO or whatever the chain of command is within your agency. As far as competencies go, we've touched on this, but ongoing education and continually to stay current and connected to what's happening, what's trending, and maintaining your credentials are all part of those competency requirements connected to your ethical responsibilities. Looking at boundaries and limitations and professional competency and integrity. Ed, these again are some of our ethical principles. Do you want to review these with the group just briefly? They're pretty straightforward. Oh, you better. There you go.
Yeah. Okay. So autonomy, allowing an individual the freedom to choose and action. Basically, the results of an assessment need to be reviewed. The diagnosis needs to be disclosed, and the client needs to have the opportunity to identify problems and have a say. Everything's negotiated in the treatment plan and the course of treatment. That's the client has those privileges, and the responsibility of the counselor is to allow those privileges to a degree, of course. I mean, within limits. Do no harm to the client. I remember one ethics course I took, it said at all costs, make sure that you keep them alive. So
Yes.
So you may want to choke them, but that would be unethical. So do no harm, mentally, spiritually, or emotionally. And of course, physically, you do no harm. It's the counselor's responsibility to contribute to the well-being, the enhancement of the individual's condition and recovery. So it's the counselor's responsibility to be beneficial, to be useful and helpful. And then also when it comes to justice, and again, treating them equally. No racial, spiritual, cultural bias can be imposed. And to be aware of your own bias and any relevant differences that you may have with the client may have with the program. It's the counselor's responsibility. The counselor has the greater responsibility to address these issues and mediate concerns and problems. And then fidelity, faithfulness to the cause, do what you say, say what you do what you say, operate with integrity and honesty above all. In my whole career, if I have a counselor trainee, I'm going to tell them, don't you ever lie to a client. If that ever comes out, you're ruined. You're just absolutely ruined. So that's that comes in with this fidelity, being honest and as genuine as possible. Now, having said that, sometimes we have to shade the truth only at the benefit of the client, but never lie. Don't violate their trust in any way, shape, or form.
Thank you, Ed. We don't have time today to talk about the ethical decision-making model, but it's something that if you're interested, this is a 7-step ethical decision-making model that is often utilized in academic settings, but certainly has a place and an application in a clinical setting as well. So ethical decision-making model by Van Hoos and Paradise is something to consider. Well, let's talk a little bit about setting professional boundaries. Very important in the work that we do because it can often be highly emotional and very difficult. So maintaining boundaries and setting those early and often is crucial, as many of you know. But again, the guidelines for this: do no harm. This non-maleficence recurs. We see this theme recurring again and again and again. It's my mantra, do no harm. Transference and countertransference are also, I don't think we need to condemn this, but I think it needs to be accepted as it occurs and to be aware of it and to address it and respond or not respond appropriately. But transference and countertransference do happen. It's real. And anyone that says they haven't experienced one form of it or another probably is not being upfront. So transference happens. Ethical boundary guidelines continue, making sure that we are avoiding dual relationships. And these are very clear. Dual relationships are not allowed in every single ethical code that I've looked at. Considering sexual and affectionate feelings versus behaviors. A patient may express this to you, but if there's no behaviors, then it can be addressed and boundaries can be reestablished, making it clear, I'm here to work with you therapeutically. Our relationship does not include this type of disclosure or behavior. And then the idea of bartering for services, this quid pro quo. I mean, it's, again, seems pretty obvious, but I was telling Ed the other day, as we speak right now, there is probably a clinician having their patient mow their yard as a way to pay down on their bill. If you can think of it, it's probably happening right now. So ethically, it is not allowed. Is it illegal? That's another matter. Mandatory reporting, we've touched on the Tarasoff decision and mandate from 1976. Duty to warn. We also want to include this idea of having, as a behavioral health or social services provider, we are mandated to report child abuse or adult dependent abuse, as well as the sexual misconduct of a clinician or provider. Using supervision. Here, I have something in the chat here. Yes, that's right, Donna. I agree. Social media really can be can really make things a little blurrier. My message to my staff was no social media references, and if you're putting something on social media, you're also in the community. You're also representing yourself professionally. So.
I can interrupt for just a moment. There are many, many people I've heard of and experienced it myself, that if somebody finds you on Facebook, that, and sending those friend requests, and that's an opportunity for a discussion. And that's why I'm not on Facebook, but a lot of problems. And it just gives an opportunity to discuss again, that relationship is strictly professional, and to not, I would suggest not being Facebook friends with anybody that's a patient.
That was actually in our policy, in our
Yes.
program, that a counselor, clinician, any staff person having any kind of a clinical relationship with current or past clients could not befriend them on Facebook or Faceblog or any other kind of social media that may be out there. It was prohibited, forbidden. The potential for breach of confidentiality is extremely high. If they make any reference to having been in your program and you acknowledge that, you just broke their confidentiality.
Yeah.
Or if they are asking about former clients or that type of thing, any response to that breaks confidentiality. So,
well, and it's also the dual relationship thing too.
Yes.
Absolutely. Yeah.
For sure.
We don't get to be friends with them. We can be friendly, but we can't be friends with clients or former clients.
Yeah, thank you. Thank you for that, Donna. And I agree. And I may be the only person here that isn't on Facebook, but I've never had Facebook. I don't plan on having Facebook. So it was an easy one for me. But yeah, others are much more active in social media. So we wrote it into our policies and procedures at my previous clinic as well. Using supervision. We've talked a little bit about this, touched on this, the idea of testing out approaches and concepts, rationale and practices. Supervision can be a great venue or platform to talk about this, trying something new or different with your patient group. From a administrative standpoint, that clinician or that supervisor may ask, how many patients do you have? What's your caseload? Taking recommendations and putting them into action. So I'm recommending intensive outpatient. How do we make that referral? What's the process there? How do we do this in an appropriate, responsible manner? And also, from an administrative and clinical perspective, helping you as a provider learn the broader scopes of practice, and also really asking, as a supervisor, asking your staff, what kind of clinician do you want to be, and how do you want to be portrayed and engaged with your patients. Patients often will not remember what you said or did, but they will remember how they felt when they were with you. And so sometimes that can be an underlying guide for engaging with patients in a responsible, ethical, professional way that's also meaningful and purposeful. I want to touch, we don't have a lot of time, but I do want to touch on this idea of using supervision with Native practitioners. And this next slide, I'm just going to turn the floor over to Ed so we can just have a brief discussion about this. I know we are approaching the top of the hour, and I know we want to try and get a break in. So I think we will try and get a break in pretty soon. But Ed, I wanted to turn the floor over to you.
Okay, so in a Native American program, I think it's vital. It's imperative that you have some form of connection to traditional Native American leaders, elders, spiritual leaders, that type of thing. So in our program, we had a contract with a highly regarded spiritual leader that was available to clients as needed. Of course, in our program, we sweat at least once a week. Sweat lodge was a very important part of what we did, but there were other ceremonies that were also conducted, performed for the entire staff, for the clients, and also individually as needed. So that's that resource is very important. Also, the role of a clinical supervisor, again, as well administratively, I'm going to do your employee evaluation, but more importantly, it's my responsibility to help you as my supervisee to develop clinically, mentally, emotionally, spiritually, grow as a clinician. So that's another responsibility. Training needs to be incorporated to protect people, when to ask for help, how to ask for help, and who to ask for help from. This works as an agency and interacting with spiritual leaders, as well as personally staff and their development, and most importantly, in the delivery of culturally based practices with the clients. So there needs to be resources available.
Ed, can you see this slide okay? It's just a visual example of different communication styles.
Yeah, and in here there's a concept of linear thinking versus global thinking, kind of encompasses this. But Native Americans tend to be predominantly global in thought processes. Non-Indians, Europeans, Americans tend to be more linear. That's not hard and fast. I know some linear natives, and I also know some global thinking non-Indians, but in general, this is how this plays out. So these are different styles of communication and interaction. You want me to go hit on each one of these? And
I don't think we need to. This will be available to everyone in the PDF version of this, but it's just a nice visual and to give you an example of the differences oftentimes that can be seen between communication styles with indigenous practitioners versus non-native or Western communication styles.
I have a 2-hour workshop on this if you want.
I know. I think I'm already signed up for it, so I'm ready.
Okay.
So we're going to. I want to ask the group. We've been going now for just about 90 minutes. What I'd like to do is take a short break, let everybody rest their eyes, maybe use the restroom, stretch a little bit. When we come back, we have 10 ethical questions, quiz questions that we would like to, as a group, go through And so be prepared to maybe post an answer if you're comfortable doing so. There are multiple choice questions. When we come back from break, we're going to go through this 10 question quiz, and then we'll talk about our breakout rooms with our ethical dilemma vignettes. So let's take just a short 10-minute breather, and we will see you guys. Let's see. I've got just past 11 Central. So let's try and meet about 10 after the hour, okay? And we'll do a quiz. Be ready.
So Steve, do we have them divided up into groups yet or not yet?
Not yet. We'll do that after the quiz, and we'll do breakout rooms based on how many we have. We've got 40 on the call, so we'll probably break into groups of 9 or 10, or actually we've got 5 vignettes, so it'll be a little bit smaller groups, maybe 7 or 8. But we'll do that when we get back. Okay. See you guys in about 8 minutes now. See, Ed, you've cut into their break time already. See you guys in a couple minutes.
Well, you should have told the global thinkers they got 5 minutes, and then the linear thinkers 10 minutes. So.
That's right. Yeah, see you in 5 minutes, all you linear thinkers.
Global thinkers.
Oh, yeah, global thinkers. Well, want to welcome everybody back here. Let's get started here. A couple more minutes, and we'll try this. We'll try and go through the 10 quiz questions. I hope you guys can stay on for the second half of this. If you're not able to understand, you would still be eligible for 1.5 CEUs of ethics. If you're able to stay with us for the second half of the broadcast, we'll make sure you get all 3 ethics CEUs. So happy to see our attendance remain pretty strong. I hope you enjoyed that little respite. And I see Ed is still with us, so that's good. And why don't we go ahead and move into this quiz? Now, these quiz questions are multiple choice. They're based on some of the information we've talked about, and there is one correct answer. There are some distractors, and there are also some answers that are just completely incorrect. So let's see how you do. And I think what we'll do is we'll look at the question, and then if you're comfortable chiming in chat with what your answer is, then we can kind of talk about this. I have on the line with us to assist for the second half. I have Meg and Parker from our Native Center for Behavioral Health here assisting us. So welcome, Meg and Parker. Glad you guys are here. I'll try not to break anything. but if I do, I know you guys will be right there to help me. So why don't we look at that first quiz question? Ed, are you ready to see how ethical this group is?
Oh, they look pretty ethical, but now let's look deeper and see what they're made of.
I thought Doug was looking rather ethical there this morning. So well done, Doug. Let's take a look at question number 1. A treatment counselor is contacted by a patient's medical doctor who's interested in obtaining information about the patient's progress. The patient has given verbal permission to release information. The counselor should. What do we think? There are your choices. The patient's doctor is called wanting to know how they're doing. They're asking for some progress. Okay, we've got, I see Lachelle is chimed in saying C and E. So the patient has given verbal permission to release the information. What do you do? This is a little tricky. This is Ed's fault because he made me change this quiz question up a little bit. So it's kind of tricky. Okay, so the correct answer here is C. You do not release information due to confidentiality. Ed, why is that?
Because if you're going to release information, it has to be backed up in the client's file with a 42 CFR compliant release of information form signed.
Yes.
If you don't have it,
yes,
when they call, I don't care if it's their mama, the papa, the grandpa, all you can say is, no, well, I can't say that, but due to federal regulations of confidentiality, I'm not at liberty to disclose any information regarding your request.
Yes, yeah. So, and Ed reminded me, and it's important to remember that verbal consent does not equal written consent. It must be written.
So the client just seen the doctor, they just came out of the office, they call you up as a counselor. My doctor is going to call, go ahead and tell them. You know, that's a scenario that I see this. And it's like, No, you got to get your button here to sign a 42 CFR compliant release of information. Then we can talk to the doctor.
Yes, that's right. So correct answer here is C. We would not release any information. And you may go back to the patient and say, I need your written consent. Your physician has contacted me. I'd like to send them a brief progress report. And then you would get the patient's written consent and then follow that accordingly. So does that make sense to everybody? Yes, Doug says get one signed. Yep. Question number 2. A situation that would not justify a breach of confidentiality would be, your choices here. Which one of these would not justify breaking confidentiality? Yes, I see Tanya. Yes, you guys got this one. Yes, the correct answer here is C. This is an example where the patient selling drugs in order to support his substance use disorder. There may be some legality to this. There may be some concern to this, but you would not be required nor allowed to breach the confidentiality because of that. All the other ones would be potentially reason to breach. Make sense? Yeah, that's a good question, Allison. Is verbal consent ever appropriate to take in the era of COVID-19 due to telehealth and working from home quarantine? That's a great question. And I know I do some consultant work with a local treatment center here that's all telehealth, and all of their ROIs in telehealth do not need to be signed by the clinician. There needs to be documentation that it's reviewed and signed by the patient. So there are some addendums and exceptions to that, but I'm afraid I'm not as familiar with some of those. But it's a great comment and question. I appreciate that.
I heard that laws are being written now to accommodate this.
Yes.
So,
yeah.
and I know there's some leniency. I know in our certification board, there is leniency regarding COVID. So,
Yep, I agree. But great point, Allison. Thank you. Question number 3, an old friend of a clinician who has his own private practice suffers from a substance use disorder. Since he wants to help his friend, the clinician agrees to counsel his friend twice a week without charging for the sessions. This arrangement is it ethical or unethical or neither? Yeah, you guys are on. You remember that dual relationship. That's what we have here. I think it's a disservice to the provider as well as the patient. And it's a dual relationship. So D is the correct answer. Well done.
And what makes this most unacceptable is that it's his friend. So it isn't the waiving the fee. Agencies can do that, but it's his friend. That relationship makes this unethical.
Yeah, the relationship is compromised and it's unethical. Question 4, after a clinician has written a case study on one of her patients and submitted it to a professional journal for publication, the clinician supervisor, who is a well-known psychiatrist specializing in substance use disorder treatment, edits the document and writes 2 paragraphs. When the clinician lists the supervisor as the first author and himself as the second, the clinician has acted. Is this ethical, unethical, or neither? So you have a prominent psychiatrist who has contributed to this article, and the counselors listed them first. What do we think? And this one's a little tricky because you may not run into this as often, but Ed and I talked about this one too, and it's the correct answer is E. It's unethical. The clinician should have listed themselves as the first author, and the psychiatrist who contributed in a minor way as the second author. So it's an ethical violation that probably wouldn't get you hauled away or in trouble legally, but it's one of those violations that needs to be noted. Let's look at question 5. A patient who has been in therapy for 6 months informs her counselor that she's going to end her life. She claims that she has a gun at home and will use it that evening. The counselor's best course of action would be this is the best course of action. And think prioritize. Think prioritizing this. All of these options, with the exception of maybe one, is something to consider. But what are we doing here? What are we doing? Okay. Harold, I like where you're going. I like this. The correct answer, Tanya's got it too. The correct answer here is B. An evaluation or a no harm contract or an emergency assessment team, those are all viable and may be something that happens in the continuum, but the correct answer here is to initiate hospitalization.
Remember, we have to keep the client alive.
Yeah.
So
yeah. Okay, that's good. Question 6. Your patient who was just sexually assaulted knows who attacked her, but doesn't want to press charges. She says a trial would be too disruptive to her family. She lives in a small town. Her children are in junior high, and her husband has a high-profile position in the town's largest company. What's your first responsibility? What's your first responsibility? Ethically, what are you responsible for here? What's your first responsibility? Yes, you guys are on. You guys are on. The correct answer here is B. This is a medical priority, and then looking at some other components to this situation, but medical attention confirmed that she's gotten that. So does that make sense to everybody? Question 7. The goal of confidentiality is okay, look at them coming in. Yeah, you guys are right on. Goal of confidentiality is to protect the patient. Well done. The goal of ethics. What's the goal of ethics? Based on our discussion today and what you know, what's the goal of ethics? Think about each discipline, each field having its own code of ethics. What's that designed to do? Yes, you're on. You guys are on. It's to protect the profession. That is the goal of ethics.
it does protect the client, it does protect the counselor, but the goal is to protect the field.
Yes, that's the overall goal. Those other ones may also be benefactors, of ethics, but the primary goal is to protect the profession. Question number 9. Which of the following presents the greatest risk to confidentiality? Greatest risk. Now, again, Ed and I had a bit of a discussion with a course we taught out in Montana late last year regarding this question, but which of the following presents the greatest risk to confidentiality? Yes, let's see, what do we got? Yes, we have some mixed reviews coming in. We knew this was coming. Yeah, this one got me too, you guys, when we first. So, let's think of it this way. All of these potentially could be a risk to confidentiality, but which is the greatest? According to the writer of this question. According to the author and his or her experiences.
Here's
Correct.
here's a clue. Which one do you have the least control over?
Yeah. Which one has the most moving parts? Yeah, so this is a tough one. Yeah, Harold's onto it. Sasha's onto it. The greatest risk to confidentiality here is a large family in a therapy session together. All these other ones potentially are there could be confidentiality risks or breaches possible, but C is the correct answer here. We could process that a bit, but I want to keep moving. Think of it though as this is the greatest risk when put into this context. Final question. An adolescent outpatient treatment provider is contacted by the patient's father, who is asking whether his daughter has been attending group sessions and if she has been reporting continued abstinence from alcohol and other drugs. The adolescent patient has given permission to release information to the father only regarding attendance participation. The counselor should So you have an adolescent patient, we'll say she's 17. She's been attending treatment sessions with you and your group, and you're seeing her individually. The father calls and asks for whether she's been attending and remaining alcohol and drug free. What do you do? You have a release of information. We'll say it's a written release, but she's only checked attendance and participation. Yeah, so this is a little tricky, and maybe I need to reword this, but you can share with the father, the concerned other, in this case, the father, you can share with him whether she's attending and participating only. So you would give the father only the information on participation. You could not confirm whether or disclose whether she was reporting continued abstinence, because she's not giving you permission to release that specific information. Does that make sense? So we know, filling out ROIs, that patient can choose what is released and shared. Now, in the state of Iowa, adolescents are afforded identical rights to confidentiality when it comes to substance use disorder treatment. And I believe that is replicated throughout the country in other states. So that isn't an issue, whether she's under 18 or not. So the correct answer here is B. I would disclose to the father that she is attending or she is participating, and that's all I can disclose. So, all right. I hope that was somewhat helpful to just to get your sort of analytical mind thinking a little bit about what what you would do or how you would answer certain questions regarding ethical considerations or decisions. So we're going to spend the remainder of our time together, which we've got just about a half an hour. So I want to try and jump right into this. What we're going to try and do is we've got 36 of us on. So I'm going to try and place the group we have randomly into 5 groups. So there'll be 6 or 7 of you in each group. What we're going to ask you to do is to look over some vignettes, and Group 1 will have vignette 1, Group 2 will have vignette 2, etc. So depending on which group you're in, you will be provided a vignette. And what I think I'll do, Parker or Meg, if you guys are on, what I'm going to try and do is post these in the chat, and then we can cut and paste those into each group. So ethical dilemmas can cover a wide spectrum of difficulties that each of us may face in the behavioral health or helping professions field, including the management of confidentiality, third-party information, child protection and welfare, competency, self-disclosure, setting boundaries, etc. Ethical dilemmas often arise without any warning in our day-to-day work. The following are, it should be 5. We added one. Oops. We added an extra vignette. Donna insisted that we add one more vignette. I'm kidding. She asked if we could add one more. So there are 5 rather than 4. Each of them involves possible ethical dilemmas that you might see in a real life professional setting. Now, there are no clear and hard, correct answers to each of these vignettes. I think there are certainly some pathways that would be deemed questionable in assessing these, but there are several pathways through each of these vignettes. What I'm asking each group to do is to spend 10, 12, 15 minutes discussing them as a group, and we'll come back and maybe have just a little bit of time to talk about these. But I think we go until 12:30, so I think we're going to be okay time-wise. So if you guys bear with me, what I'm going to try and do is, Meg or Parker is asking me, do you want us to moderate? Do you want us as moderators in the breakout rooms? I think that would be fine. It might help, just help us manage things a little bit. I might be able to also, as the host, I might be able to drop Ed in to check on each group and see how you guys are doing as far as your discussion goes. But I think what we'd like to do is introduce the vignettes, and each group will have, if you're in group 1, we'll let you know that, and you'll be assigned that vignette. So my hope is to give each work group a vignette. So bear with me as we split up into random small groups, and then we'll make that vignette available to you specifically in your group room. So I'll try and post those in the chat once you get into your group rooms. Does that make sense for everybody? Ed, any other questions, or Meg or Parker, do you have any thoughts about this?
Oh, let's do it.
Let's try it. Okay, so I am going to let's see if I can get the breakout rooms feature going. So there's 35 of us, 35 participants. So we've got five vignettes. So I'm gonna do 5 group rooms, and I'm gonna assign these automatically. So I'm gonna create those. So each of you will be in a group room with others, and we'll introduce the vignettes to each group room here just in a few minutes. So I'm going to open the rooms. Let's take 15 minutes or so to review these vignettes, and then I would designate someone in your group as sort of a recorder or someone that's comfortable reporting back because we'd like to hear from each group and how you guys assessed and handled the ethical dilemma. So I'm going to open the rooms now. We'll see you guys in about 15 minutes, and we'll talk about each vignette if we've got a little time left. Oh my gosh, I've been muted this whole time. Welcome back, everyone. I want to just apologize for getting the vignettes to you a little bit later. We've got about a half an hour, so I think if we're mindful of our time, we should be able to hear from each respective group and how you all navigated your way through each of these vignettes. So let's start with group one. Ed or Donna, anything to add to that before we get started?
Nope, sounds good. I know we have a great reporter for our group.
Oh, wow. That's wonderful. Well, I don't recall who made up group one, but if someone would like to give us their thoughts or notes on the ethical dilemma vignette one, Donnie.
Hey, Steve, it's Monica.
Hey, Monica.
Hey. So we had a great discussion in our group. What we recognized first off, foremost is some conversation around the note in general and anonymous information not being credible. It could potentially cause a lot of harm and even be malicious intent.
Yeah.
So first and foremost, the note would not be discussed in any manner, and there would also be no response given to the sender of the information. We collectively agree that the ethical and legal responsibilities are for the client first and foremost, above all, and a high level protection of the therapeutic relationship between Donnie and the EAP counselor. We did also have a discussion, and it was brought up, which was a good point, that if the anonymous information includes information regarding unethical behavior or safety issues that could harm patients or other clients, that the counselor should follow their standing operating procedures and chain of command to their own mandated reporting routes for that. We had a little bit of time discussing this, the tone of collateral information at the clinical table when you are triaging patients for clinic or discussing cases. What is sort of the tone at your agency of shared collateral information, and just gave an example of, a lot of our tribal behavioral health programs are staffed by tribal members working in the community, inclusive of the community that we're serving. So there's just a lot of collateral information that can come to the table, and what is the tone at other people's agencies for receiving that or not receiving it. So it's a good, excellent conversation.
Yeah, I really like that idea, and I like the idea too of exploring to rule out, to make sure that there's no one is in danger, or making sure that that's reviewed and run through protocol and your ethical decision making. So that's great. Other comments about vignette one, or anyone else in the group or outside of the group?
Yeah, I just add that the mental health problem, that's a little fuzzy.
Yeah.
But if it includes suicidal homicidal ideation, then the counselor has an obligation to report.
Yeah, I agree. These are meant to be a little vague, and remember we talked about, this interpretation process of how the ethical decision-making process can apply. Sometimes it is based on some subjective interpretation and having to assume or fill in the blank. So I thought you guys did a nice job, Monica, and appreciate your reporting back to the group. So thank you. Let's talk about vignette two. Who's reporting for group two? And we're going to talk about Linda and Tracy.
Hello, can you hear me okay?
Yes, we got you.
Okay, there were several discussions on this. The fact that one thing we'll start with is that we're all reporters. It was just who to report to, clinical supervisors.
Yeah.
The fact that there's a child in the house now with the perpetrator. So there was many different things to do, but a lot of us, we started off with saying we disclose it to our clinical supervisor and kind of move on from there. And that's-
Is this dilemma ethical and legal? Is there a mandatory reporting element to this vignette?
We had serious divided opinion on that, Steve.
Yeah.
Some said, no, it's not mandatory reporting. And at least one of us said, yeah, it is.
There's definitely some gray area in this vignette. I was also divided on whether or not there was a clear and present danger, and whether or not that was grounds for filing a report. I think
There were actually, I divided it into two. There's two issues on the table. The first one is mandatory reporting. Tracy discloses to her counselor that she was sexually molested at the age of 9. Now, to me, that's pretty crystal clear. That's mandatory reporting. We have a perpetrator. We have an allegation of sexual abuse. That's mandatory reporting. The other issue is, and I don't think Tarasoff comes into play here as a duty to warn. However, there's a moral and a responsibility to follow up. And I think in our discussion, the conclusion I came to, if this is reported to child protection, then that would cover everything. Then they would take it from there. And but there were differing opinion.
Yeah, there's some, when I read through this too, I was wondering, how long ago this occurred with Tracy, and wanting more information about timeline and which is this an exception to confidentiality? The agency policy is to provide total confidentiality to patients.
But if it's a mandatory reporting, that overrides your 42 CFR.
Well, good discussion on this, and I appreciate you guys tackling this tough case. And there are some pieces here that are left out, I think, that make it harder to find a clear pathway through this.
I love that comment. Yep. East Coast versus West Coast. We talked about so some of the one of the most powerful dynamics came up is tribal sovereignty regarding how they deal with these things. So if it's dealt with the tribal social services, end of story, and it'll be taken care of appropriately. But I know in South Dakota, this has to be reported to Child Protection Services. And
So
again,
it really does depend on the agency and the location too.
Yeah, like I said, there's local dynamics that come into play. But in South Dakota, and I've spent most of my career here, except I've been other places. But this is a mandatory reporting issue. This has to be reported to Child Protection services. And I gave, the example. I had one lady, she was sexually molested as a child, and the perpetrator was dead. And this was like over 20 years ago. And I called CPS and I said, what do we do with this? She said, that is mandatory reporting. So I counseled the client into actually making that call and reported her sexual abuse 20 years ago with a dead perpetrator. It was still, I was still obligated. I was told that in South Dakota, that's a reportable.
Well, I want to make sure we get to the other vignettes, but I really appreciate the dialogue here, and it does sound like there are some considerations to apply local for local and state regulations. And I saw Polly had put in some Oregon mandates that would dictate sort of the course of action she might take in this case. So that's great. Thank you very much for everyone's work on this difficult vignette. Let's take a look at the vignette 3. This is involving Nancy and Terry, and who was in group 3 and would like to report on their decision making here.
I took some notes for vignette 3, but anybody can chime in and add to what I wrote down as well. So we discussed a little bit about how we could give Terry a timeline, and that it was good to go to her first, but there were also some considerations of the vignette not having all the information. So how are the patients being affected, and how is maybe Terry's work being affected with that in consideration? And what are the lines between the colleague and friend relationship?
Yeah.
And then, so how does it come into play in the workplace? And then it needs to be reported if there is evidence of it being affected. There was also talk about being a gatekeeper and having honesty. So maintaining professionalism and mutual accountability in the field. Kind of reporting as soon as you know, things like that.
Well, that's great. I appreciate that. Others' thoughts about this or this vignette? This one was, I can say having worked in a clinic for many years, there were instances where we had concerns about clinicians or support staff being impaired and having certain protocols that we would follow, including an EAP referral and trying to get that staff person some support and help, keeping in mind some of the ADA protections and the EAP options as well as FMLA. So other thoughts about vignette 3? I think the underlying theme too, I'll add this, is that there is a kind of collegial and peer relationship that is happening between Nancy and Terry. So that I think that complicates or clouds Nancy's ability to act or to take some decisive action. I don't know if you guys agree with that or not.
I actually had a real life scenario with this, and where that wound up was allegations of heavy drinking don't hold water.
Yeah.
If there's like a DUI or some other legal entanglement or civil involvement like child protection or social services, that makes it more concrete. But just an allegation of heavy drinking, that puts it in a very, very gray area. Even though, as a friend and a colleague, that they got an issue, but legally, you got to be careful. Ethically, have a talk with the individual. If they got no ears, they got no ears.
I know in certain disciplines, medical and nursing and dental professions, an impaired professional is a serious matter. And there are state agencies that address impaired professional physicians and require them to engage in and follow certain protocols to make sure they're not providing services to patients impaired. But Ed's right. I mean, it's allegations and assumptions sometimes can be difficult to use as a reason for some sort of report or intervention. So it has something you have to be careful with.
Yeah, this one was reported to the certification board, and the certification board said there's nothing we can do here.
Yeah.
They the individual denied it. So it's one person against another. There was no concrete evidence. So noted in their file, but nothing could be done.
Yeah. Okay. Let's see. We've got about 15 minutes, so I think we're okay time wise. Everybody okay moving on to the next vignette? Okay. Let's take a look at vignette 4. Who was in group 4, and what did you guys come up with here?
We had some different discussion. One is I noted I just took my LCSW exam in December, and part of these questions are like, I call them social working questions, because it was, if our policies don't have this kind of leave, then it's kind of my job as a social worker to advocate for that policy change. So that was one thing to happen. Is if we don't allow religious leave, cultural leave, then we probably should be working with our policies to make sure we do. Yeah. The other thing we talked about was that a lot of us in the group, all except for 2 of us, were from the same agency, a tribal agency in Southern Oregon. And so, we know what our workplace would do. And I've worked for other agencies, and you would get the time off, even if you didn't have enough leave, you would get leave without pay. But you would probably likely be able to get the time off. But then we talked about kind of that ethical consideration about canceling appointments. If you want to say, oh yeah, it's Friday and I'm going to be gone next week. Whoa, you just canceled 22 appointments, or however many appointments, and who's covering your groups. And so there's also some of that discussion that has to happen around, any kind of leave. So part of us were like, ooh, next week? Really? If you're a CIT with, maybe you don't have a full load as a CIT, but you probably have some appointments in some groups. And so, we talked about some of those. Ultimately, we decided that they would likely get the leave. Absolutely, they should get the leave. But, when you look at your agency policies, how do they address different types of leave? And, what are your religious beliefs, and do they support all, ceremony and religion? And again, coming from a tribal agency, yeah, they'd get the time off. That was kind of where we were, is that they'd get the time off. It may or may not be paid, and that's that getting the time off and getting paid for the time off are 2 different issues. And so we identified our policies probably need looked at and reviewed. Well, we all agreed that most policies have, that disclaimer, other types of leave will be considered on a case-by-case basis.
Yes.
Almost every policy says case-by-case basis.
Yeah.
So that it would likely probably fall under that. But we also discussed how, in a tribal agency, not an issue. And probably most government agencies, because of their recognition of what, their kind of liability is in religious freedom, probably no issue. But the biggest issue might be in the nonprofit sector.
Yeah.
If you're in a non-native nonprofit, that private nonprofit is a little bit different than a public agency.
Yeah.
And that could, so it's really agency specific. It's also, we discussed how it's a really good supervision opportunity to talk to your CIT about what notice looks like.
Yeah.
How do you plan your leave? And so we had some conversation around that.
That's great. Polly, thank you. That's really similar to what I was, my train of thought, having experienced, not necessarily in the cultural context, but having experienced, an intern or a practicum student or a counselor in training, maybe not being familiar with some of the leave requests or the protocols. So having a teaching moment there, and then I think the other aspect would be to review policies and procedures and to sort of adhere to what the timeline for leave requests are. And bereavement, for example, is something that is often unplanned, or something that you just sort of drop what you're doing and they're gone, and then we fill in and cover for them. So, but I thought you guys did a nice job. Other comments or thoughts about Vignette 4?
Can I just add my 2 cents worth?
Please, Doug.
This is Pollock. No. If I was a new CIT and I really believe that I needed to take that week or so off for Sundance, I would probably inform the supervisor on being hired that this is an obligation of mine and I have to do this every year. So just an FYI.
Yeah.
My vacation time if I need to.
Yeah, good point. And any other closing thoughts on this vignette?
Nope, I just know that tribal programs that I've been in, they will accommodate. And for Lakota Sundance, it's 12 days.
Yes.
And they are accommodated 100%.
Yeah.
So whether it's leave without pay, well, we get spiritual leave and an annual leave, and even sick leave is granted. We call it stress leave.
Yeah.
So this participating in Sundance is a mental health as well as a spiritual opportunity for healing.
Yes. I like the 12-day window too. So you can recover and get yourself ready to come back. Okay, let's take a look at the final vignette, which I did not have added into this slide deck, but let me see if I can post it. Yes, there we go. I've just reposted this in the chat. This is vignette 5. Can everyone see that posted there? This is regarding patient Robin with medical condition, who was in group 5 and would like to give us their pathway through this ethical decision-making process.
I was in there, but let somebody else speak. Come on.
So our group decided that this situation was unethical. The reason being Robin, she grew up with a medical condition, and it wasn't until Robin reached maturity that her mother decided to have the guardianship. And it sounds very self-serving money oriented because she depended on the extra income that Robin's disability provided. However, it became when Robin was exhausted by the medical conditions and she wanted to discontinue her medical life-saving interventions, and Robin's mother was adamant that all measures should be taken. The medical staff should honor Robin's wishes to be able to stop the life-saving interventions for a couple of different reasons. One, depending on the state, you have the right to end your own life. Steps can be taken to reverse guardianship. And it just sounds very, like I said before, self-serving on Robin's mother's part, that it's driven by money.
Thank you very much for that report. Yeah, this was that the DNR issues like that are always tough for me anyway, to keep my emotions out of it. But yeah, other comments about this final vignette, or I thought you guys did a nice job navigating through that, and I agree with your assessment. Donna, any thoughts about this this vignette?
No, I think they did a really great job. Yeah, it's that intersection of legal and, ethical, and, that's a tough one, but honestly, I would side that way too.
Yeah, I agree.
Yeah.
Well, I want to, as we get ready to wrap up, I just wanted to again thank Ed and Donna and our support team, Parker and Meg, for coming on for the second portion of this to help support us and gosh, you guys got tossed right into the breakout room. So, wow. You can thank me later. But I really did enjoy sharing with all of you today and hearing from all of you. It was great to see some familiar names and faces. Just to kind of summarize today's module, some things to remember, that non-maleficence, beneficence, and really trying to do the right thing and do no harm. We really reviewed and talked about ethics and some of the legal components and some of the values and morals connected to those ethical decisions. Patient rights. We talked about patient rights, particularly confidentiality and privacy. And your ethical practice can greatly impact the quality of patient care and how people view our profession. Boundary issues, sometimes they can start off very small, with very small improprieties, and then develop into something much more serious. I remember one time we had closed the clinic. I had a final session with an adolescent patient. It was dark and it was a blizzard, and they left the clinic, and I got in my car and left, and I was about 2 blocks from the clinic, and I see them walking in this blizzard with not much of a coat on, and I made a decision at that point to stop and give them a ride home. And it was one of those, my instinct said, don't give patients rides. That's how I was trained. But in this case, I felt like, it was the right thing to do. And I went back and spoke with my supervisor about giving this patient a ride home. And I documented it, that given the sub-zero temperatures and the snow, that it was okay to do this. And it was approved and documented, and nothing became of it. And that patient of mine was very, very appreciative, because they were walking in snow and without the right, clothing on. So it was, but my point is, boundary issues sometimes seem innocuous, and sometimes they can develop into something more problematic. Quiz questions, you guys did great, and I really appreciated the small group discussion today on those ethical dilemmas. You guys were all right on, and it makes me feel like we've got a pretty ethical group here. So well done, well done. Thank you again. And any closing thoughts or comments, Ed or Donna?
You want to just maybe do another quick review on CEUs and how people can access those?
Yes. So we will be reaching out to all of you based on your attendance for today's event. And we will give you the opportunity at that point to request CEUs. And you just need to let us know whether you need social work CEUs or the NADAC substance use disorder CEUs. And we'll make sure we get those out to you, and you will get 3 ethics training CEUs for attending today's session. So hopefully that will satisfy your state requirements for your ethics CEU hours. And you need 6, Doug? Well, we got you halfway there, brother. You're almost there. So anyway, I want to say again, thank you very much for your time and your participation. And it really means a lot to me. And I know Donna and Ed also appreciate it. So until next time, we're going to broadcast next month. Donna, I don't have the topic in front of me, but we're going to broadcast first Thursday of next month. And so look for an advertisement or flyer and registration for that event. And we'll be hopefully looking for you then. So thank you, everyone. Until next time, stay safe, stay connected, and stay healthy. And
Thanks everyone for coming. Appreciate
thanks,
it.
everybody.
Later.
Take care. Signing out.
Bye.
Bye.